Levels and patterns of mortality, as it applies to population change. Contents. Introduction. Levels of mortality. Issues with measurement. The model age patterns of mortality. The regional life tables. What is in-depth surveillance system? The 7 in-depth patterns of mortality. Introduction. Accurate data on mortality conditions in Africa are still scarce. Until recently, the main tool for bridging this gap was the use of indirect demographic estimation techniques and model age-specific mortality schedules produced by Brass and colleagues, 1973, Cole and Demeny, 1966, and the United Nations Department of International Economic and Social Affairs, 1982. The Brass relational system is based on empirical data collected in West Africa during the middle of the 20th century. In contrast, neither the Cole and Demeny nor the UN model life table systems use significant amounts of data collected from Africa. Moreover, all 3 of the systems are based on 30 to 50-year-old data. Given the dramatic demographic changes that have affected Africa in the past 20 to 30 years and the fact that 2 of the systems are based largely on data collected from other regions of the world, whereas the third is based on data from only one region of Africa, it may be problematic to use them in the current African context. No doubt, the World Fertility Survey, WFS, and the Demographic and Health Surveys, DHSS, have remedied the above situation in part by increasing our knowledge of the level, trends, and differentials in infant and child mortality in the developing world. Also, since independence, several African countries have undertaken national censuses, but mortality data from these sources are often plagued with underreporting and need, therefore, to be adjusted using hypotheses that are not always realistic. Levels of mortality. It is seemingly very easy to classify mortality into three levels than actually identifying the distinct levels with respect to the region in questions, the age structure of the population, and of course the mortality regime existing in those regions coupled with the underlying customs and traditions of the people. However, the 3 levels of mortality are very high, high and low.
Issues with measurement. Apart from the census data, mortality is difficult to measure. This is particularly so for maternal mortality. The reasons for this are multiple, but mainly relate to measurement issues, including the underreporting and misclassification of pregnancy as a cause of death and the relatively small numbers of maternal deaths involved, in statistical terms. Many pregnancy-related deaths still go unnoticed or unreported, and substantial errors in the estimates of maternal mortality persist, even in industrialized countries. Bouvier-Call et al. 1991. Schweitmaker et al. 1997. Correctly measuring maternal mortality not only requires complete registration of deaths in women of reproductive age, which in many countries may be lacking, but also the recognition that the woman was pregnant or recently delivered at the time of her death. Deaths during early pregnancy, such as those because of abortion or ectopic pregnancy, are often not recognized or reported as pregnancy-related, and death certificates often omit the notion of pregnancy. In settings where vital registration is weak, special studies are needed to correctly measure the levels and causes of maternal death. In the rural West African context, where most deaths do not occur in hospitals with reliable medical records on hospitalized patients, retrospective confidential inquiries are not feasible, and verbal autopsy is a useful retrospective method to find out about the medical causes of death. Chandramohan et al. 1994, Mungra et al. 1999. This method is based on an interview with people who are knowledgeable about the events leading to death, based on which physicians assign a cause of death. Verbal autopsies provide broad categories of the causes of maternal death as well as contributing factors. The model age patterns of mortality. Much of the developing world is not adequately covered by accurate vital registration systems, leading to a substantial lack of direct empirical data describing mortality. Because planning must still be undertaken, Information on mortality is inferred through interpolation or extrapolation from existing commonly observed age patterns of mortality, the so-called model life tables. These model age patterns of mortality are used to substitute, extend, or fill in where observed mortality data are missing and are often key ingredients in methods used to estimate demographic indicators from sparse data. Underlying epidemiological profiles are inferred based on those that are known to underlie the existing model of mortality patterns that most closely match the observed data. The closest fitting model patterns are then used, among other things, to estimate levels of child mortality and create population projections. The regional life tables. The model age patterns of mortality will be discussed in detail in subsequent topics. However, the models are Coldemini West, Coldemini North, Coldemini East, Coldemini South, UN General, UN Latin America, UN South Asia, UN East Asia.
What is in-depth surveillance system? The International Network for the Demographic Evaluation of Populations and Their Health, or in-depth, is a global network of research centers that conduct longitudinal health and demographic evaluation of populations in low and middle-income countries, LMICs, currently in 52 health and demographic surveillance system. The in-depth system proposed seven different patterns of mortality for developing countries like Nigeria as follows. Pattern 1. The first pattern is similar to the Coldemini North and UN Latin American Model Life Table Age Patterns of Mortality, In-Depth Network, 2002. There is no indication that HIV/AIDS affects Pattern 1, and the male and female age patterns are similar with the exception of a bulge in the female pattern during the reproductive years, presumably caused by maternal mortality. Pattern 1 is primarily derived from sites in West Africa over the entire period covered by the in-depth network dataset. HIV/AIDS has not yet become as significant a problem in West Africa as it is in Central and Southern Africa, so a large impact of AIDS in the data from West Africa is not expected. It is worth noting that child mortality between the ages of 1 and 9 is significant and substantially elevated above the most similar existing models. This is in keeping with the fact that malaria is a significant cause of death in West Africa, and it has a large impact on those ages. Pattern 2. The INDEPTH network Pattern 2 is derived largely from Asian data, and for that reason is not discussed here. Pattern 3. The sites contributing to Pattern 3 are almost exclusively located in Southern Africa and East Africa, South Africa, and Tanzania in particular. This pattern obviously contains some influence of HIV/AIDS, but not nearly to the degree observed in Pattern 5. The South African data come from the Agincourt site, where mortality is extraordinarily low compared with the other in-depth sites in Africa, and where HIV/AIDS is recognized but does not yet affect the population in the catastrophic sense that it does in other parts of Southern and East Africa. The remainder of the data come from the Dar es Salaam site, where the impact of HIV/AIDS appears to be greater. This pattern is most similar to the UN Far East pattern of mortality, corresponding to the low infant and child mortality compared with mortality at older ages. A noteworthy feature of this pattern is that infant and child mortality does not appear to be substantially elevated, as might be expected when HIV/AIDS is an important contributor to mortality. Timaeus, 1998, suggests that the strong secular decrease in child mortality that has been observed in many settings in Africa during the latter half of the 20th century may largely cancel out the increase in child mortality brought about by HIV to yield approximately unchanging child mortality, rather than the increase that might be expected when HIV is having such an easily observed impact on adult mortality. Pattern 4. Pattern 4 is a variation on Pattern 1, with the important difference manifested in the 35 to 69 age range. At all other ages, Patterns 1 and 4 are negligibly different except that infant and child mortality in Pattern 4 is consistently slightly lower than Pattern 1. But between ages 35 and, roughly, 69, pattern 4 reveals significantly higher mortality than pattern 1. This pattern is most similar to the UN general pattern for females and UN Latin American pattern for males. As was the case with pattern 1, most of the data contributing to pattern 4 comes from West Africa. Pattern 5. The HIV/AIDS pattern of mortality is most clearly visible in pattern 5. The data contributing to pattern 5 are derived from the 3 Tanzanian sites run by the Adult Morbidity and Mortality Project, AMMP, in Dar es Salaam, Hai, and Morogoro. There is a striking bulge in the mortality of males between the ages of 20 and 54, and for females between the ages of 15 and 49. The female bulge is significantly narrower and more pronounced, corresponding to the earlier infection of the female population, and within a tighter age range than the male population. This pattern is not particularly similar to any of the existing model patterns, but it is most closely matched with the UN General female and Latin American male model patterns. Pattern 5 differs from pattern 3 mainly in the shape of the HIV/AIDS impact. The effect is more diffuse with age in pattern 3, meaning that mortality is elevated through a broader age range, the magnitude of the elevation is more consistent, and the differences between the sexes are less apparent. Pattern 3 is derived largely from the Dar es Salaam data, and this may reflect the fact that the epidemic is more mature in Dar es Salaam and has consequently had enough time to infect a wider age range of people of both sexes. As with pattern 3, it is worth noting that infant and child mortality do not appear to be substantially affected in a manner comparable to adult mortality. Pattern 6. Pattern 6 is one of the 2 additional patterns identified in the female data. It is an interesting pattern that reveals high mortality of children and teenagers, and comparatively low mortality of infants and adults of all ages. This pattern is exhibited by sites in northeastern Africa and West Africa, with most of the data coming from Ethiopia. Without additional information, it is not possible to speculate on what may be producing this unique pattern. The male pattern is most similar to the Coldemini North model pattern, and the female pattern is closest to the Coldemini West model, both of which embody high mortality in the same age ranges. They deviate from those patterns in that infant mortality is substantially less than would be found in either model pattern, and child and adolescent mortality is significantly higher. This might be called the Super North pattern. Pattern 7. Pattern 7 is the other additional pattern identified in the female data, and it, too, is interesting. It is derived from 2 sites located in Central and West Africa. The reason it was identified in the female data is obvious. There is a substantial bulge in the female age pattern between ages 25 and 44. This pattern comes mainly from one small site in Zambia, so it is probably not worth extensive interpretation. The corresponding male pattern is similar to pattern 6, and both are similar to the Coldemini North model pattern. The North model pattern contains relatively high child and teenage mortality coupled with comparatively low mortality at older ages. This is consistent with the fact that malaria is an important contributor to mortality in both sites. Conclusion. In their 1996 review of demographic models, Cole and Trussell, 1996, described the identification of empirical regularities as one of the central motifs of demographic modeling. Their term accurately describes the formulation of model mortality schedules and hints strongly at the limits of their usefulness. Because there are no general, reliable, theory-driven models of the individual risk of death, we must rely on commonly observed patterns to guide us, empirical regularities. Because these are simply commonly observed patterns, however, we must be careful not to inappropriately overinterpret them or substitute them for a thorough understanding of the mechanisms underlying the risks of death that lead to each pattern. Beyond being the first step in understanding these mechanisms, identifying underlying empirical regularities in age patterns of mortality is still a useful exercise in its own right. With fertility and to a lesser degree migration, mortality shapes the size and age composition of a population and is consequently of great interest to policymakers who must adequately plan for the future of a population. Mortality is one of the most valuable indicators of the health of a population and, as such, is of critical importance to those who manage health care infrastructures. As a sensitive indicator of where a population is and where it will be in the near future, knowledge of mortality is a vital component of population planning and management. Existing systems of model life tables include systems developed by the Population Branch of the United Nations Department of Social Affairs, 1955, in the early 1950s, by Cole and Demeny, 1966, in the early 1960s, by Lederman and Breas, 1959, in the late 1950s, by Brass, 1971, in the late 1960s, and finally by the UN again in the early 1980s. United Nations Department of International Economic and Social Affairs, 1982. Only two are in common use today, the Cole and Demeny system and the 1982 UN set. However, neither of these systems was formulated with anything more than trivial data from Africa. Apart from the West pattern that appears to contain a small amount of data from the white population of South Africa, none of the Cole and Demeny patterns is based on data from Africa. And apart from a small amount of data from Tunisia, neither are the recent UN patterns. The lack of empirical data from Africa underlying either of the commonly used model mortality systems is a significant problem for demographers working in Africa, as Preston, Huveline, and Gallo, 2001, eloquently state. A limitation, common to all the systems discussed so far excluding the 1982 UN models, is that their empirical basis consists almost exclusively of the experience of developed countries. Most applications of model life tables, however, are addressed to developing countries with incomplete data. Making this problem worse is the dissimilarity of the epidemiological profile of large parts of Africa to that of the developed world. It is clear that malaria and HIV are primarily to blame. Both increase overall levels of mortality and may affect certain age groups disproportionately. The significant endemic prevalence of these two diseases is responsible for vast excesses in mortality in some of the harder-hit age groups, malaria for young children, and HIV for children and young to middle-aged adults. It is clear that the existing model mortality patterns are not appropriate for use in Africa, given that they were not built using data from Africa, and that there is good reason to believe that the mortality profile of Africa is different from other parts of the world. Until now, however, there has been no alternative. It is to begin addressing this need that the In-Depth Network has compiled a database of primarily African empirical mortality data and has begun to identify common age patterns of mortality described by those data. In-Depth Network, 2002. DSS site data are sometimes challenged as being unrepresentative, Lopez et al. 2000, of surrounding constituencies due to the history of clinical and community-based intervention trials that are conducted in such populations from time to time. However, there is little evidence that the mortality patterns in trial sites are markedly different from those prevailing in similar settings nearby, where trials have not been conducted. The reason for the paucity of evidence is that most trials are conducted on a subset of the population, and they target a specific cause of mortality. Usually the interventions do not continue after the trial, unless they are adopted as broad implementation policy, for example, insecticide-treated nets, whereby the non-trial areas are, within a few years, at the same level of coverage for the intervention. We must also appreciate that our health system interventions have relatively weak modulating effects on population mortality compared with secular trends in socioeconomic circumstances and environmental forces. We should recognize that the modest population size of a DSS site does not constitute a major flaw, however, as even sites monitoring small-sized populations can produce robust measures of age-specific mortality when data are aggregated over a period of several years. Moreover, data collected over long periods of time from the same population living in the same area can reveal important age-specific trends in the risk of death. Furthermore, when data from a number of widely dispersed sites are brought together, they provide both a geographically and temporally representative measure of mortality conditions. At present, only DSS sites provide data that can be used to depict the temporal and geographical contours of mortality patterns in Africa. Thanks.